diabetes, irrespective of their DKD phenotype. So again, providing us with some confidence that treating patients with low levels of albuminuria, at least in the type 2 diabetes population, is worthwhile. And we know that in people with and without diabetes, these agents reduce the risk of hospitalization for heart failure, and that effect is also consistent irrespective of albuminuria. So in summary, when we look at all of the evidence in context, we've got evidence not only from EMPA Kidney, but EMPA-REG Outcome, EMPEROR, and all 13 SGLT2 inhibitor trials, that these agents safely reduce the risk of not only kidney disease progression, but hospitalization for heart failure, cardiovascular death, all-cause hospitalization in a broad range of patients with kidney disease. Patients with low levels of albuminuria and low GFR remain at high risk of many of these adverse outcomes, and treatment of these individuals should take into account all of the benefits of this class of medication, not just kidney disease progression. I think there is less evidence perhaps in patients without diabetes and low levels of albuminuria, and certainly that is work that we're doing through the SGLT2 Trialist Consortium to better understand what the benefits and harms may be in those groups of patients. Thank you very much for your attention today.
Thank you very much, Dr. Bendo, for the fruitful lectures. I think we have a lot of the information about the SGLT2 inhibitors in low eGFRs and low albuminurias. I think we have to move to the important lectures in the lecture 2 about another benefits of SGLT2 inhibitors. Okay, let me ask you to join the renal checkpoint 2 again. Please scan QR code to participants and answer the questions. Okay, in the checkpoint 2, we asked you about when do you initiation SGLT2 inhibitors in CKD patients by using the KDIGO heat map. You have to start at the green box or yellow box or orange or red box in your practice, or the E is you did not initiation SGLT2s in the CKD patients. Okay, please answer your questions by the I think we have a lot of discussions after that. most participants answer the yellow box, okay, and orange box, and a little bit the red box, okay. I think this is the overall of the SGLT2 inhibitors in CKDs depend on the KDIGO heat map, okay. I think yellow is maybe the more data or many try or the meta-analysis that is approved about the SGLT2 inhibitors, okay. Okay, let me move to another, important questions about in patients with albuminuric status of A1, the reduced hospitalizations. I think probably maybe the heart failures, okay. And C is a delay initiation dialysis. C is a start dialysis, maybe HD or PD or transplantations. D is reduced proteinurias or albuminurias. Some people might think about it's only the surrogate outcome or it's maybe impact of the heart outcome. Okay, and finally, I'm not sure about the delayed mortalities in your patients about this. Let me move to the important lectures about the EMPA kidney and SGLT2 inhibitors across the full spectrum of kidney functions and albuminuria. Please welcome Dr. Bendo again.
Thank you Thank you very much, Professor Pawina, and some very interesting responses there that hopefully we'll have a chance to discuss later on. So a question I'm often asked is, how low can we go with starting an SGLT2 inhibitor? And I think this is worth talking about today, given that the minority of you in the audience were initiating SGLT2 inhibitors in patients with stage 4 CKD. Before we had EMPA kidney, we had, at least in type 2 diabetes, evidence that the effects of this class of medication on kidney disease progression, defined as worsening kidney function, kidney failure, or death due to cardiovascular disease, were evident across all levels of GFR studied down to a GFR of 30 to 45, at least in patients with type 2 diabetes. Then after that, we had the DAPA-CKD study that demonstrated that, in fact, initiating an SGLT2 inhibitor down to a GFR of 25 was effective. And you can see here data that was written up by Glenn Chertow from Stanford, looking at the effect of dapagliflozin in patients with stage 4 CKD compared to patients with high levels of kidney function. And what you can see is overall clear benefit on the primary outcome and other outcomes, although slightly smaller numbers, so slightly wider confidence intervals, demonstrating that even in stage 4 CKD, the drug is effective to use to prevent kidney disease outcomes and progression. What about safety? That is sometimes quoted as a concern. And when we look at the risk of adverse outcomes overall, we know that SGLT2 inhibitors are very well tolerated. There are not many medications where the risk of serious adverse events is less common with the active compared to placebo treatment, but that is the case with SGLT2 inhibitors across the class. And these are the safety events in patients with stage 4 CKD compared to patients with high levels of kidney function. And what you can see is overall no increased risk of serious adverse events, in fact fewer serious adverse events overall, and that effect is similar in patients with stage 4 CKD compared to higher levels of kidney function. So certainly reassuring evidence from clinical trials that starting an SGLT2 inhibitor in patients with advanced CKD is not only effective, but safe too. How about in EMPA kidney? That recruited very large numbers of patients with GFR less than 30, over 2,200 patients in fact. And when we look at the effect of empagliflozin on the primary outcome of 40% decline in GFR, kidney failure or death due to cardiovascular or kidney disease, you can see it's essentially a straight line. Empagliflozin reduced that risk by 28%, consistent regardless of the patient's level of kidney function initially. What I'm going to show you on the next slide is maybe, hopefully, something you have not seen before. And this is unpublished data from EMPA kidney. What this showed is EMPA kidney had a very long lag time between screening and randomization. So although it recruited patients with a GFR greater than 20, for about 8 weeks, some of those patients, their GFR dropped to below 20, sometimes even down to 15 or 16. And you can see here that about 250 patients had a GFR less than 20 by the time they were randomized. And no evidence whatsoever that the effect of empagliflozin is attenuated down to GFRs of down to below 20. And, you know, that is just so remarkable when you think about, 8 years ago when Credence was conceived, and there were heated discussions in the steering committee about whether or not we should even study patients with a GFR of 30 because the effect on glucose is attenuated in CKD. Who would have thought almost 10 years later now we'll be initiating these therapies or using them in patients with GFRs less than 20? And certainly I can say from my own practice and those of my colleagues in Sydney, Australia, that we are now comfortable using this drug even in patients down to a GFR less than 20. So on the basis of the EMPA kidney trial, as well as the EMPEROR studies in heart failure that recruited patients down to a GFR of 20, that SGLT2 inhibitors are now routinely recommended in the latest KDIGO guidelines down to a GFR of 20, you can see here, and that therapy should be continued until dialysis. So don't stop if the GFR falls below 20, continue until dialysis or transplantation. Because there has been no evidence whatsoever to date that the effects and the benefits of this class of medication are modified by baseline kidney function, there is substantial interest around the world from not only nephrologists but other physicians about whether or not we can use these drugs to reduce adverse outcomes in transplant patients and even in patients on dialysis. And I'd be very interested to hear from my colleagues in the audience today what your local practices are in Thailand. But we are involved in a large outcome trial being run by the Netherlands. We're participating in Australia. Patients in Germany, Belgium are also participating. This is an investigator-initiated trial called the Renal Life Cycles Trial, and it's recruiting 1,700 patients, a third of whom have advanced CKD, GFR less than 25, a third on dialysis, a third with kidney transplants, and evaluating the effect of dapagliflozin on a primary outcome of hospitalisation for heart failure, dialysis or death from any cause. And this will give us really important efficacy as well as safety information in these patients that have not been to date included in landmark kidney outcome trials. So we're just about to recruit our first patient in Sydney, and recruitment has already started in Europe. And so hopefully we will have results over the next few years in even dialysis patients with residual renal function like those on PD. So that's across the levels of kidney function down to the lowest levels of GFR. What about different levels of albuminuria? I presented some of this data so far, so I'm not going to go through this again. At least in type 2 diabetes, I'm confident that the drug is beneficial for kidney disease progression regardless of albuminuria. I'm less certain in non-diabetic kidney disease, and that remains to be seen. When this is unpublished data that we are just starting to look at, and hopefully we'll be able to share with the broader clinical community in the next 12 months or so, is the effect on kidney disease progression across all levels of albuminuria, regardless of diabetes. So you can see here there is more data than my initial Lancet diabetes paper. But at the moment, there's no evidence that that effect on kidney disease progression differs whether or not you have albuminuria or not. Really interesting and provocative data. Of course, many of you will ask me, well, I want to see the non-diabetic low albuminuria data. And of course, I would like to too. We have not seen that, we have not analysed that. So hopefully within the next 12 months, we can share that with the broader clinical community. Although EMPA Kidney demonstrated that perhaps the magnitude of benefit was greater in people with higher levels of albuminuria, we must take a broader view of the class of medications and the types of events we're trying to prevent. And going back to Professor Pawina's slide about when you are initiating an SGLT2 inhibitor, my answer would be, it depends on what type of event you're preventing. Of course, you can treat people in the green KDIGO category if they have heart failure and you're trying to prevent heart failure, or if they have atherosclerotic cardiovascular disease. The absolute risk reductions for kidney disease progression might be low, but there might be clear benefits for heart failure. So we have to think broadly about not just the kidney, but cardiovascular events. And the data from EMPA outcomes show that you can prevent cardiovascular events regardless of albuminuria, and the heart failure data indicates that you can prevent heart failure hospitalizations regardless of albuminuria as well. So when you are seeing patients, I urge you to think, what type of events are we trying to prevent for this patient in front of me? And of course, the optimal thing is to think about risk, not only in terms of GFR and albuminuria in isolation, but putting those two things together as is done in the KDIGO heat map. And is it possible that we can identify patients who would benefit most in absolute terms by using the KDIGO heat map? Well, we have looked at that in the SGLT2 inhibitor outcome trials. These are data from Canvas in people with type 2 diabetes, looking at the effect on cardiovascular outcomes across different KDIGO risk categories. And you can see here that in relative terms, in the top portion, the effect on non-fatal MI, non-fatal stroke, cardiovascular disease, the effect on cardiovascular death or hospitalization for heart failure, and the effect on heart failure, no evidence that that relative effect differs by KDIGO risk. So consistent benefits in relative terms and consistent benefits for the kidney outcome as well. But we should be thinking about absolute risk reductions, not only relative risks. So what the KDIGO heat map does is it allows us to identify the patients who are going to gain the most in absolute terms. So take, for example, the effect on the primary outcome in Canvas of non-fatal MI, non-fatal stroke, or cardiovascular death. You can see here that for every 1,000 patients treated over 5 years, we would typically prevent 23 patients from experiencing this event. If you target patients at very high risk, you can prevent almost 170 events for every 1,000 patients treated over 5 years. Take again, for example, cardiovascular death or hospitalization for heart failure. We can prevent 23 events for every 1,000 patients treated over 5 years. But that absolute number of events prevented increases such that in very high risk patients, you could prevent a substantial number of people experiencing heart failure or cardiovascular death if we target patients at the highest KDIGO risk. This is data from the EMPA program that in heart failure, the heart failure cardiologists are not really using the KDIGO heat map as much as we are using in nephrology, but they have applied it to heart failure patients. And reassuringly, they found in heart failure patients, the effect of empagliflozin is consistent across different KDIGO risk categories. And so there is a benefit not only for hospitalization for heart failure, but also total hospitalizations for heart failure and for cardiovascular death. Again, we should be thinking about relative effects, not only, we should be thinking about absolute effects, not only relative effects. And what we did was we pulled data from the Canvas and Credence trials, 14,543 patients with type 2 diabetes with a wide range of kidney function, a wide range of albuminuria, and looked according to GFR and albuminuria, not only kidney disease progression, but heart failure and cardiovascular death and everything combined. So all outcomes. You're trying to prevent MI, stroke, cardiovascular death, heart failure, kidney disease progression, and what are the absolute risk reductions? Well, if you look overall on the left-hand panel, you can see here that for every 1,000 patients treated over 2.5 years, we would prevent 41 patients from experiencing a composite of MI, stroke, heart failure, cardiovascular death, progression of kidney disease. But that benefit is largest in people with low levels of kidney function, GFR less than 45, and patients with high levels of albuminuria. And that pattern of effect of larger absolute risk reductions across lower levels of GFR and higher levels of albuminuria is also evident for the heart failure, kidney disease progression composite outcome. So patients with advanced CKD, such that you're likely to see in a typical nephrology clinic, are the ones who stand to benefit most from an SGLT2 inhibitor. So in summary, across the full spectrum of GFR and albuminuria, we now have confidence that this class of medication has been studied and is widely effective at preventing a number of events, cardiorenal events. We know that this therapy reduces the risk of kidney failure, cardiovascular events, hospitalization from any cause, and mortality across a wide spectrum of patients. And because most of these patients have overlapping phenotypes, they may not only have kidney disease, they might have some HFpEF or heart failure or have diabetes. We should take a broad view of this class of medication and the evidence that underpins it. KDIGO classification system, as I've outlined, can help us to identify those patients who benefit most from an SGLT2 inhibitor because those patients at highest risk on the KDIGO category, risk categories are those who are likely to experience the largest absolute risk reductions. Thank you very much for your attention tonight.
Thank you very much for the excellent talk that summarized the EMPA kidney. I think we have the two lectures that is introduced about the benefits of SGLT2 inhibitors, especially the EMPA glyphosine. I think after that we have the case sharings that is important for the clinical practice, I think. And we move to the case sharings that let me introduce Associate Professor Khachorn Nopakul. He is an Associate Professor of Department of Medicine, Faculty of Medicine, Chiang Mai University. He is a member of Thai transplant registrations, Thai renal replacement therapy registrations, Nephrology Society of Thailand, and committee member of Natural Licensing in Transplant Medicine, Thai Transplant Society. Please welcome Associate Professor Khachorn, please.
Thank you very much, Professor Pavina, and very excellent talk from Dr. Brennan. So for my part, I will show the case discussion, and Professor Pavina and Dr. Brennan will join us to discuss this case, and we also welcome the audience in the meeting room to discuss this for this case. So this is my disclosure. So we start with the case. Mr. K is a diabetic man with 62 years old, and he is a type 2 diabetes diagnosed for 4 years. And he has hypertension for 7 years, and he has no history of smoking. He also has mild non-proliferative diabetic retinopathy, but no neuropathy. And he doesn't have any history of established cardiovascular disease, including myocardial infarction, stroke, or peripheral arterial disease. His medications is just only for metformin, 850 milligrams BID for controlling the blood glucose, and the losartan for treatment of the hypertension. And he presents this time for the routine follow-up, and everything is fine. So his blood pressure is 128/78, and his BMI is 20.6, which is pretty good. And blood glucose level is pretty high. It's 146 for the fasting blood glucose, and the A1C this time is 7.6. And his urine albumin is 2+, and we quantitate the urine albumin by the UACR is 660 milligram per gram of creatinine, and he has serum creatinine of 1.49, which is equal to the eGFR around 50. So the problem is the patient doesn't have any established cardiovascular disease. His blood pressure, his BMI is pretty fine. However, he has a problem with a little bit high blood glucose, and he also has a urine albumin, which is A3, and now he has CKD G3A3. So for the further management for these patients, he has now just only have metformin and losartan. Professor Pavina and Dr. Brennan, you have any comments or for comprehensive management of these patients? Any comments?
So, I like this case because it's a typical patient who would come to primary care.
It's very typical.
There's nothing very exciting about it. And but you can see here that I think the first question you have to think is, what is the cause of his kidney disease? And I think there's enough here that suggests that this man has diabetic nephropathy. His history of retinopathy is certainly convincing. His glucose control is suboptimal. And so the most likely diagnosis here is that he's got diabetic nephropathy. I'd like to see renal imaging to make sure that there are no structural abnormalities. But I think he has kidney disease from diabetes, and reassuringly, he's on an angiotensin receptor blocker. So that's a good start. I guess the next question, Professor Pavina, is what treatments would you recommend or suggest?
I think it depends on the guidelines and this clinical assessment. We have to add the SGLT2 inhibitors. You have the uncontrolled A1Cs, I think that the best option to add the H2 inhibitors. I think the key is if you want to decrease the glucose, I will ask Dr. Bedron again about what is dose. You want to start the 10 milligrams or the 25 milligram at the beginnings because A1C is high. What do you want to start at in your opinions? Yeah.
For empagliflozin.
Yes.
If you plan to start empagliflozin for prevent the kidney progression in these patients and to reduce the urine out, to reduce the A1C in these patients, how about the dose of the empagliflozin that you
what do you think about?
we should use?
I'm using just 10 milligrams.
Yes.
10 milligrams straight up.
Because we are nephrologists, right?
Yeah.
So it's just 10 milligrams.
I don't really, I'm not too fussed. I see sometimes, if their glucose control is insufficient, you can consider increasing it up to 25. But the thing is, in people with kidney disease, especially when you get to a GFR less than 45, the glucose lowering effect of empagliflozin and other SGLT2 inhibitors is pretty modest.
Yeah.
And you might think about using other agents to reduce HbA1c. So for that reason, I'm typically using a 10 milligram dose, set and forget for everyone. It's very easy.
Yeah, okay. I think that depends on glucose lowering. If you use a high dose, it may be enough or more effective when we use only the low dose. I think this organ protection is a low dose is enough. That is why Dr. Bendo said about the 10 milligram is maybe optimum for control the A1C and organ protections. Okay, any comment from the floor? Or you want to the high dose at the beginning?
I have another question.
Yes.
If the patients refuse to take SGLT2 inhibitors with any reasons, how about the options to increase the dose of the losartan to, for example, 150 or 200 milligrams a day to reduce the urine albumin? Is there options?
We're not using a lot of losartan in Australia, but we would want to, in this case, maximize the dose of the renin-angiotensin system blockade. Certainly, this man has sufficient blood pressure to do that.
Yeah.
I know this is not evidence-based, but even in some of the younger patients who have lowish blood pressures, I sometimes dose the once-off ARB at night to help. That can help with blood pressure.
Okay, I agree with for the stable losartan because the blood pressure is normal. As you increase the losartan more, it may be induce a hypotension that may aggravate the acute kidney injuries. I think this is my answers.
Okay, so we go next. So for the dose adjustment, for when we choose the medications to treat the diabetes, it usually depends on the GFR level of the patients. For example, from this slide, you can appreciate that most of the medications can be used if the patient has the GFR higher than 60. However, when the patients have GFR lower than, for example, 45 or 30, there is limitations of the use of most of the medication except for the DPP-4 inhibitors. For the SGLT2 inhibitors, if you want to use it to reduce the glucose, most of the recommendation will recommend the use before the GFR lower than 45. Otherwise, the serum, the blood glucose is not going down after you use the SGLT2 inhibitors. For these patients, if he has a GFR with 50, so he can use all kinds of the anti-diabetic medications. For the glucose, this is the consensus report from the ADA and ESD. Now, for the goal of the management or the patients with diabetic, we will have the main goal is to achieve the glycemic control and the management of the body weight. The other goal is the cardiorenal risk reduction. For the goal for the treatment of the A1C and body weight, it depends on the medications that have the evidence to reduce the A1C and the body weight. And you can appreciate that the SGLT2 inhibitors is the group of the high efficacy to reduce the blood glucose and the intermediate efficacy, high efficacy to reduce the blood glucose and intermediate efficacy to reduce the body weight. For the cardiorenal risk reduction, as you know, that in the patients with a CKD, when the patients have GFR less than 60 or you have the albuminuria more than 30, the recommendations is the first line treatment is SCI or ARB. After that, you have to use the SGLT2 inhibitors to reduce the risk of kidney progression. For this patient, So for the blood glucose control, you can use any kind of medications as I showed in the previous lines. And for the urine albumin and serum creatinine and for the reduce the kidney progression. So the medication we have discussed that we should use the SGLT2 inhibitors. It's in accordance with the diabetic the guidelines from the ADA guidelines. In the patients who have with diabetic kidney disease, you should start with ACI, ARB if the patient has albuminuria. And they recommend that in the patients with type 2 diabetes, like in these patients, and the patients had diabetic kidney disease, if the patient still have the GFR higher than 20 and UACR higher than 200, the patient, the first recommendation is to use the SGLT2 inhibitors. Also, as Dr. Brennan said in the talk, that even the patients has the normal levels of the urine albumin, the patients can, the recommendation is suggest to use the SGLT2 inhibitors in the diabetic kidney disease patients if the GFR is still higher than 20. And it can use the SGLT2 inhibitors to reduce the risk of the ASCVD in the patients with high cardiovascular risk. So this is the paper published by the Dr. Brennan group. This show the absolute risk reductions after you use the SGLT2 inhibitors in the patients with a 1 patient years follow-up. For the diabetic patients, the most benefit, the absolute risk reduction is 5 patients will reduce the risk of the ASCVD, especially in the hospitalization for heart failure and CV death in the group with high cardiovascular risk. For the patients who has a heart failure, as Dr. Brennan showed in the previous lecture, that both in the patients with diabetic or non-diabetic. In patients with heart failure, if you start SGLT2 inhibitors, the most benefit that the patients will have is to reduce the risk of their CV death and hospitalization for heart failure. For the patients with CKD, as we show in this slide, that in the patients with diabetic kidney disease or non-diabetic kidney disease, for the prevention of the kidney disease progression is the main benefit of the SGLT2 inhibitors. For the SGLT2 inhibitors now approved for the US FDA for the treatment of the patients, it depends on the trial that, as Dr. Brennan has talked in the previous lecture, that if you want to use the empagliflozin 10 milligrams, it depends on the level that include the patients in those trial with EMPA includes patients who had the eGFR level more than 30, and for the heart failure trial, they include the patients more than 20, and the EMPA kidney, they include the patients who have the GFR more than 20. So this comes up with the FDA approved indications. If you want to use the empagliflozin for type 2 diabetes patients, the eGFR should be higher than 30. For the patients with heart failure with reduced or with preserved EF, plus minus you have type 2 diabetes or not, if the GFR higher than 20, you can use the SGL empagliflozin. And I think in the near future, and we can discuss in the Q&A session, that in the near future, for the approved for the indication for the CKD patients, it should be go to with the eGFR level higher than 20. For this patient, I decided to start the empagliflozin 10 milligrams. And 3 months after I start empagliflozin, the patient comes up with the lower levels of A1C, and UACR goes down from 660 to 420. However, the problem is the serum creatinine is rising, and the eGFR goes down from 53 to 47. So at this point, after you start 10 milligrams of empagliflozin, and the patient has rising of the serum creatinine. So what we should do next, and should we adjust the dose, stop empagliflozin, or anything that we can do? Dr. Brennan?
Yes.
So I think assuming we're seeing this patient now in follow-up clinic and they're well, they're euvolemic,
yes,
the answer is nothing. Because we know that this class of medications causes an acute drop in GFR by about 3 to 5 mils per minute initially in the first few months, but we know that that is a reflection that the drug is actually working. It is reducing intraglomerular pressure, and we know that over time we'll see a stabilization in kidney function. If you look at credence and DAPA-CKD, what we showed was that allocation to an SGLT2 inhibitor doubled or almost tripled the risk of experiencing an acute drop in kidney function. But over time, regardless of what your initial change in GFR was in the first few months, everyone was better off in terms of slowing progression of kidney disease. So I think provided this patient is euvolemic, well, this is actually to be expected and is a sign that the drug is effectively working.
Okay, in my opinion, I think we have a 3 point that we have to check. The first is dehydrations, because some patients may have a little bit some dehydrations. We have to increase the water intakes for enough to slow the dropping of eGFRs. The second is maybe to recheck the home blood pressure monitorings, because if before start blood pressure is not high, if you start SGLT2 inhibitors, blood pressure, some patients might a little bit dropping, because in the clinical trial, systolic blood pressures might be decreased to 5 milli, and maybe it drop lots of blood pressures. I think systolic blood pressure is maybe drop to 5. It's maybe a little bit changed at home. And I think the 3 point is maybe they check the nephrotoxic again. In Thailand, it is the most common if people receive the SGLT2 inhibitors, and some people after visit use and orders the herbs and supplements at the internet, something like this, is maybe the aggravate of eGFR decrease. I think we have 3 points: blood pressures, dehydration, and volume status, and 3 is the nephrotoxics. If we check is the 3 is okay, any change, something like this, you have the continued SGLT2 inhibitors and follow up again. I think these are my quick answers.
Okay, so I agree with both of you. So my decisions to do with this patient, I still continue with empagliflozin, and then we follow up these patients at 1 year, 2 years, and then 3 years. You can see that the eGFR are pretty stable, and the serum and the UACR goes down. This is the proposed algorithm. If you decide to start SGLT2 inhibitors, it depends on the level of the GFR based on the last clinical trial. For example, in the EMPA kidney, the patients who recruit is GFR is higher than 20. If you think that the patient has the indications, the GFR level is okay, so you have to decide that if the patient has type 2 diabetes or not, because this medication is still the glucose lowering medication. So if the patient has higher level of the GFR, for example, higher than 60, if the patient on the sulfonylurea or insulin, you may need to reduce the dose of the sulfonylurea or the insulin to prevent the hypoglycemia if the patient has the history of hypoglycemia or A1C less than 7. And then, as the Professor Pravina said, we have to assess the volume status and blood pressure before we start SGLT2 inhibitors. If the patient has hypovolemia, you have to decrease the blood pressure medication, adjust the dose of the diuretics. And then, if the patient comes up with a euvolemic, you can start SGLT2 inhibitors. In contrary, if the patient has euvolemia or hypervolemia, you can start SGLT2 inhibitors in combination with ACI, ARBs, or any ANI or MRA. And in some patients, if the patient has euvolemia and the patient on the loop diuretics, you may need to consider to reduce the dose of loop diuretics, maybe for example 50%, and then advise the patients for the 6-day counseling. And follow up the patients. If the serum creatinine rising less than 30, you can continue the SGLT2 inhibitors. However, if the serum creatinine rising higher than 30%, you may need to reconsider for the blood pressure, for the volume status of the patient, including the toxic medication, as Professor Pravina said. For these patients, before we start empagliflozin, we have to advise the patient for the symptoms of volume depletions, for the risk of genital tract infection, and then we can discuss in the Q&A sessions, and the stop medications with the patient becoming ill or have any need to do the surgery, or if the patient had a serum creatinine that may be rising. So that's all for my talk. Thank you.
Okay, I think we have two excellent lectures from the Dr. Bendon and share case from the Drs. Kajon Sak. I think we have a little bit 10 minutes or 15 minutes for Q&As. I'm not sure about in this room. Do you have any questions? Please raise the hands and you can ask the questions, or the participant at the Zoom, you can chat questions and we will answer your questions. Do you have any questions in this floor?
So I have a question for Dr. Brandon first. So as you said, and also in the most of the guidelines for the patients with diabetes, so SGLT2 inhibitors you can use even regardless of the level of urine albumin, and regardless of the cause of the diabetes, because most of the patients, some patients may not have diabetic kidney disease, but they have diabetes. So in the diabetic patients, I think it's pretty clear for using SGLT2 inhibitors, regardless of the level of the urine albumin. However, in the patients with non-diabetic kidney disease, so for the recommendation, if you propose for the guidelines, we don't have guidelines for now, right? So in the near future, if the guidelines come up, you will think what the guideline will, the pictures of the guideline will say about the SGLT2 inhibitors in the patients with non-diabetic kidney disease. They will have the level of the urine albumin for using SGLT2 inhibitors, or you think we can use like the patients with diabetes?
So that's a really interesting question, and I'd like to ask the audience. I'm curious to know in Thailand how many of my colleagues here are using SGLT2 inhibitors in non-diabetic kidney disease yet. Are many people using them? Some over here.
Yeah.
And
also you.
Yeah. So I think, look, that's going to be a really interesting area, seeing where KD goes later this year with their recommendations for kidney disease, CKD. Certainly, when we pull all the available data from the CKD trials, we can see that this class of medication reduces kidney failure irrespective of kidney disease etiology. So no matter whether you have a glomerular disease, and we showed that in the, I haven't showed that today, but it's in the open access Lancet article. It doesn't matter whether you have diabetic nephropathy, a glomerular disease, hypertensive nephrosclerosis, or even other causes of kidney disease, the effect on kidney disease progression is similar. And also when you break it down into subtypes of glomerular diseases, IgA, FSGS, other glomerular diseases, there's no clear evidence that that effect differs by the type of glomerular disease you have. So certainly for proteinuric non-diabetic kidney disease like IgA, we should be using SGLT2 inhibitors. I think there's very clear and convincing evidence. The uncertainty, I think, that you've alluded to is non-diabetic, no proteinuria CKD.
Yes.
And I think, if I haven't seen the data because we're still pooling all of the data, but I think what we're going to see is unclear evidence of benefit in non-diabetic low albuminuria patients, but those patients may benefit for other outcomes other than kidney disease. So if they have heart failure, they might benefit from heart failure, ASCVD, etc. Yeah. So I think the remaining area of uncertainty, I think what the guidelines will recommend is there'll be clear benefit proteinuric non-diabetic kidney disease, non-proteinuric non-diabetic kidney disease, perhaps a weaker recommendation. And the only patients that we still have uncertainty about, in my view, is you've got low GFR, low albuminuria, no diabetes, no heart failure, no atherosclerotic cardiovascular disease. How many patients do you see like that? Not very many, but I think that's where the remaining or residual uncertainty is.
Okay.
Okay, we have a question from the audience. I think the first is the patients with renal disease have a more pain from the chronic gouty arthritis and polyarthritis. What should the medications that we would like to prescribe in our patients?
I use steroid. I don't know, but I use systemic steroid in these patients. Yeah.
In these patients. What about?
I have to say, steroids, prednisone is what I go to. I'm lucky that I have good rheumatologists at my hospital who also help out with chronic gout. This is a really interesting question because, and I don't know, no one asks me this when I do these talks, but these drugs also reduce uric acid.
Yes.
And there's some evidence when you look at the trials that these agents reduce gout flares.
Yeah.
So So I don't often get asked it, but we've looked at the data in Canvas and Credence and shown that SGLT2 inhibition reduces gout flares. There's some data in heart failure patients. So I think that's a kind of off-target benefit that you may see as well, which is different to the initial question being asked.
Okay, I agree for the steroid, but I think it's from the meta-analysis that shows the EMPA or SGLT2 inhibitors can decrease the serum uric a little bit. I think if you have the high uric acid and you want to avoid this hypouric, another medications, we try to, maybe you can see a little bit decrease of uric acid. Regarding the meta-analysis that confirm about the decreased uric acid. I see that some papers from the empagliflozin is a long-term follow-up, maybe can decrease the renal stones, probably as maybe from the decreased uric acids and increased waters and maybe decreased stone in the futures. However, we have to need more data for confirm this, I think. And I think the second question is the gradients and SGLT2 inhibitor effect on the heart failures. Okay, doctor, don't please.
So I think we've got very clear evidence that not only empagliflozin but dapagliflozin reduces the rate of first heart failure hospitalization, total heart failure hospitalizations in people with heart failure, irrespective of ejection fraction. The first therapy now for HFpEF, where no therapies have been effective before, and also irrespective of diabetes. So the important thing about this class of medication in terms of cardiovascular events is they're most effective actually for heart failure and perhaps less effective for stroke, MI, where GLP-1 is more effective. So certainly the benefits are quite clear for heart failure hospitalization that SGLT2 inhibitors be used.
Okay, I think in the internist or internal practice, I think if you don't have the cardiologist for prescribe the echo for use, I think SGLT2 inhibitors is a can, is include the preserve EF or low ejection EF. It might be, have a many more benefits for decrease the hospitalization in the futures. That is, I think for internist, if you don't have the cardiologist, SGLT2 inhibitor is is a full spectrum for the heart failure.
I think that's a very good practical point. And, my cardiology colleagues, when EMPEROR Preserved came out, were debating, do you need echoes as much anymore now? Because it doesn't matter what the echo show, what the ejection fraction is. So I think that's a very important practical point.
Okay. And SGLT2 inhibitors can help to reduce the slope of the GFR in heart failure patients, right? It can protect kidney, right?
Yes. Okay. And I think we have questions about the patients have a large proteinuria after a full dose of the LAS and SGLT2 inhibitors. What is the next step that we have to move?
Start with me. Okay.
Start with you.
So I think for most of the trial, I think the benefits of the SGLT2 inhibitors you can see the benefits of SGLT2 inhibitors regardless of the urine albumin reductions. So even you start with a maximum dose of RAS blocker and you prescribe the SGLT2 inhibitors, it doesn't depend on the level of the proteinuria reductions. The patients will have the benefit from both of the medications. I think that. But if the patient has, the questions I will ask Dr. Brandon later, if the patient has diabetes and they have the SGLT2 inhibitors and RAS blocker, and they still have albuminuria, for example, is there any roles of new medications, for example, non-steroidal mineralocorticoid antagonists in those patients?
So I'm glad you asked that question because I'm really excited about the role of combination therapy for kidney disease, the way that the heart failure cardiologists talk about guideline-directed therapy for heart failure. Soon we will have guideline-directed therapy for CKD. And what we showed in Credence is that on average, if you are treated with an SGLT2 inhibitor and you've got diabetic nephropathy, you reduce proteinuria by about 30% on average. And that level of proteinuria, we looked at patients who were treated with canagliflozin at 6 months after they were treated and looked at how much proteinuria they had and what was their risk. And the interesting thing is you look at their albuminuria after an SGLT2 inhibitor and the risk lines up perfectly with placebo-treated participants and their albuminuria at baseline, illustrating that the residual albuminuria, as this person has alluded to, is still the strongest predictor of ongoing risk, and that means we need more therapies. Now, in Australia, we have just had finerenone approved, and hopefully we'll be able to access it and subsidise through the government in August or so. And so typically, if I am seeing a patient such as that who has type 2 diabetes, I will be adding on 10 milligrams of finerenone, provided their serum potassium is less than 5.
Yeah.
That is an effective way to reduce their residual cardiorenal risk. If you don't have a non-steroidal MRA, many colleagues are using, spironolactone or eplerenone if you can access it, although the evidence is less strong there.
Okay.
And certainly in obese patients, if you can get it, we know that GLP-1 receptor agonists also reduce albuminuria in type 2 diabetes and also reduce atherosclerotic cardiovascular events. And so on one hand, you have SGLT2 inhibitors that reduce heart failure. On the other hand, you've got GLP-1s that reduce MI and stroke. And so combining those two medications is inherently attractive. And the problem is access, of course, and I'm sure that's the same in Thailand as it is in Australia, but we are starting to use combination therapy in that way more now that Ozempic is getting a bit easier to access.
In diabetic patients.
In diabetic patients.
Diabetes patients.
And, and in non-diabetic patients, we've just finished recruitment for the finerenone non-diabetic kidney disease trial, 1,600 patients with non-diabetic CKD, about a quarter with IgA nephropathy.
Yeah.
And hopefully in about 2 years or so, we'll have evidence for that therapy. So I think it's the backbone of therapy is going to be RAS blockade, SGLT2, non-steroidal MRA. And the interesting thing is, and this is all about the concept of pillars of therapy for CKD, 4 pillars, for diabetic nephropathy, RAS blockade, SGLT2, non-steroidal MRA, and GLP-1. The hyperkalemia problem you get with MRAs, or SGLT2 inhibitors reduce hyperkalemia. We've shown that. So maybe the SGLT2 inhibitors facilitate and help us to use the other organ protecting medications.
Okay.
For these 4 pillars, so for my questions is that the first one should be RAS blocker.
Yeah.
What is the second one?
SGLT2.
Okay.
And I say that because one, it's easy to use, no dose adjustment, no acute kidney injury, no hyperkalemia, no drug-drug interactions.
Yes.
Yeah.
Probably the easiest one to use.
Okay, I asked not the truth, it's 3. If you prescribe the metformin, SGLT2 inhibitors, what is the next between non-steroidal MRA or GLP-1 receptor agonist if patients still have the residual albuminuria? Yes. What is yours?
In my opinion, for now, I think it should be non-steroidal mineralocorticoid receptor antagonist because we have evidence. We have to wait for the evidence from the GLP-1 receptor agonist for the large trial in kidney disease trial. Yeah.
So my answer, Professor Buena, is it depends on the patient. So if they have, you have 2 patients. One of them just say runs a bit, the potassium's a bit higher. Diabetic patient run with a bit of type 4 RTA, and they're obese. GLP-1. Okay. If their potassium is okay and they're not overweight and weight is not as much of a problem, I go non-steroidal MRA. So I think it's in the last few years we've had the trials that established the drugs as building blocks, the pillars, and now the next 5-10 years will test different combinations of medications, and we can then individualize it based on the patient.
Okay, we have I think it's the most common concerns about the hyponatremia after receiving SGLT2 inhibitors. Do you have experience that the patients have a hyponatremia after receiving these drugs?
Yeah. I don't think it's very. I don't think it's common. It's very common for the development of hyponatremia after SGLT2 inhibitors, especially if the patient has uremia. In some patients with hypervolemia from the heart failure, the patients may develop hyponatremia. Even we have the evidence, right, that SGLT2 inhibitors can help to treat the hyponatremia in the patients with SIAD, for example, but we don't use it in routine practice. I think it's not common to have hyponatremia after SGLT2 inhibitors.
What do you
How about
think?
your experience?
Yeah, it's not a recognized adverse effect of SGLT2 inhibitors. And if I did see it, I'd be thinking about looking for other causes of hyponatremia apart from the SGLT2 inhibitor. Sure, you can probably withhold, but I don't think it's related to the SGLT2 inhibitor. I had one of my colleagues had a patient who had quite bad hyponatremia after initiating an SGLT2 inhibitor, and it ended up being a lab error. So, I don't think that it is a commonly recognized side effect of SGLT2 inhibitors. And as you have mentioned, there's some evidence that it may help increase serum sodium levels in people with hyponatremia or SIDH.
Yes, I agree. It's very less conditions about the hyponatremia after receive the SGLT2 inhibitors, because I think the sodium balance is a water, not a sodium intake alone. But it's a little bit concerned about if you advise the patient high water intakes and low salt intake, very low salt intakes. I think it's the elderly. We have to, if you're concerned, we have to monitor. But in my experience, and I think the colleagues' experience, is we don't have the hyponatremia in after receive the SGLT2 inhibitors. That is mean it's very special conditions, very low salt intakes and the more waters alone, and it may be a little bit of hyponatremia. In the clinical practice, you don't worry too much about the hyponatremia. Okay, I think it's the another questions about if go to the kidney transplantations, and I think if the patients have post-transplant diabetes, what is the loss of SGLT2 inhibitors? What is your opinion? The key man, Dr. Kashwansak, the key man of transplant in Thailand.
I have some experience with the patients with, I use SGLT inhibitors in transplant patients. Even there is no evidence from the randomized control trial, but there is randomized control trial for now. I saw the evidence from Korea group. They reported retrospective studies in the patients with kidney transplant, and it seems like SGLT2 inhibitors it can help to reduce the urine protein, and for the allograft function or the for the acute rejections, there is no increase in the acute rejection, I think. But we need to wait for the results of the randomized control trial that is ongoing in your team, right?
Yeah, I agree with that, because it's a publication in the transplantations that is, I think, the last years or in the early this years, about the publication from the colleagues about the transplant patients that is improve allograft.
It seems safe. The message from that paper is safe for using in the patients with kidney transplantation. But is it effective to reduce or to preserve allograft function? We have to wait for the result of the randomized control trial.
What about?
Look, I'm personally not using SGLT2 inhibitors in transplant patients. Interestingly, my colleagues who I work with in Sydney, everyone has varying levels of comfort with the degree to which they will extrapolate the evidence to transplant patients. At the moment, I'm not doing it, and I'll enroll my patients in renal life cycles, and I'll wait for the randomized evidence. That's my personal opinion, but it is a grey area, and I accept that people will extrapolate that evidence. Is anyone using it here in transplant recipients, or they're waiting? No.
Okay.
Oh, maybe. So okay.
Okay, let me ask about the safety from the EMPA KIDNey about if the patient has a develop cancer, do you still use the EMPA KIDNey? I'm not sure about what is the concern about the side effects in the cancer patients. What do you think about this?
Look, I think it depends on what event you're trying to prevent, what the prognosis is from the point of view of cancer and the other comorbidities and functional status. If this is someone who has breast cancer, for example, and they've had curative treatment, then I see no reason why you wouldn't continue treatment. If they've got metastatic cancer with a limited life expectancy, then of course, as the physician, you're going to be rationalizing their medications. There's no signal that these drugs can potentiate or accelerate cancer growth. So I think we can be reassured that they're two separate issues here. It doesn't impact it.
Okay, I think that we have two questions left.
Yeah.
About
One question, I think it's about type questions, nephrology board questions. If you have large proteinuria, but you have low blood pressure, so what will you do?
So, you know what I would do? I would use an SGLT2 inhibitor without a RAS blockade.
Okay.
Potentially, some people might disagree with me, but if you don't have blood pressure for a RAS blockade, when we pull the available data, and about 20% of patients in the SGLT trials, on cardiovascular outcome trials, were not on RAS blockade, we see that the benefits are similar with SGLT2 inhibitors, regardless of whether patients are taking or not taking a RAS inhibitor. And in heart failure, where HFrEF, many patients have lowish blood pressures, the drug is still effective and quite hemodynamically neutral. So I think in those types of patients, I would be using it without a RAS blockade.
Okay.
Okay, and I think there's some questions about the additional survey between the DPP4 and SGLT2 inhibitors for aim to decrease the residual UACR. What do you think about combine DPP4 and SGLT2 inhibitors in the setting of the persistent or high UACR? I think this is a question.
I think we have some evidence that DPP4 inhibitors can reduce the urine albumin in some types of DPP4 inhibitors. For example, linagliptin. But in the whole group, I think if you can comparing with the GLP-1 receptor agonist, I think there's much of the evidence that GLP-1 receptor agonist can reduce the urine albumin. If you can convince patients to use the injection medications, I think this is the good choice for combination with SGLT2 inhibitors to reduce urine albumin, as Dr. Bendon said.
Yes, okay. And in elderly patients, do you think about it's a safe? I think it's maybe safety profiles of the elderly in the SGLT2 inhibitors. What do you think? We have a concern in elderly more than the young girls.
So I think it's a good question, and it's something that I typically think about a lot in clinic, because the patients with CKD I see, many of them are much older than were recruited in the trials. But if you look at the trial evidence we have to date, there's no evidence that the benefits or harms differ by age. And you look at the trials with the oldest patients, the heart failure trials, they recruited many patients who are older than 75, many patients who are over the age of 80, and those patients still benefited from an SGLT2 inhibitor, and treatment was still safe, even in the frailest patients with heart failure. So I think I personally make a holistic judgment. When it's difficult, when you see patients, you kind of make that judgment, I think. But certainly there's no age alone is not a reason to not use an SGLT2 inhibitor, in my view, because we've got evidence that it's safe and effective even in elderly patients. But of course, that's a judgment that you make.
Yeah, I think it's maybe the limitation time is the last question about the eGFR less than the 20. Do you have any specific analysis or post-hoc analysis in terms of the lower eGFR?
Yeah, so yes, you're right. That is a post-hoc analysis. And so we have to interpret it with some caution, but given the evidence of consistency we have all the way down from 90 all the way down, I think it's quite compelling. And if you look at the number of events, substantial number of events in that GFR less than 20 group, of course, we're going to have more information with upcoming trials. But, what is the difference between a GFR of 18 and 21? I think we're going to be increasingly using these drugs in patients with lower GFR over time.
I think due to the limitation of time, I think I will close the Q&A sessions. Thank you, Dr. Bendon and Dr. Khachon Saksuchois about the Q&A. Okay, thank you very much for your joining.
Thank you. Thank you very much.
Okay, and I think during the prepare the computers, I think you can, Okay, we have the post-event questions again about how confident are you that your patients are at a high risk of chronic kidney disease are optimum management. What is your confidence when you listen to the great talk from Dr. Bendon and share case from the Dr. Kajon Sak? Okay, could you please join the QR code and okay, 100%. Wow. Okay, I think it's a great answer for this meeting. Okay, let me move to about the second questions about do the current data provide the confidence that SGLT2 inhibitors can help minimize the risk or the progressions of cardiovascular disease and renal events in patients with chronic kidney disease. Okay, please join QRs and voting share your confidence to us again. Okay, go through the wow. Okay, I think the 80% is maybe the things about SGLT2 inhibitors might be minimize cardiovascular and renal events as organ protections. Thank you very much for joining us about the the pools and the votes. I think we have maybe the 5 minutes that I would like to summarize the key that we talked for the host meeting for today's. I think we have maybe the 5 key takeaways from me. Okay, let's start with I think the CKD is a global disease burdens. As you can see, the most CKD is around here and around the world that is increasing. The incidence is more common. I think this slide shows the systematic review from the 5 countries that show the CKD is very high incidence, that is maybe 2% at the advanced CKD and maybe lap up to the 70% in the early CKD, that the green, that I think the CKD care is maybe came to the, the internist care, not only the focus the nephrologist care, because if you see the very high risk, you don't have the gapping for preserve is very a little bit and maybe not success if you have to refer to the early stage of the CKD. I would like to share you about the tip of iceberg that you can see the CKDs in the, some patients might don't have any symptoms because they may develop the CKD stage 1, 2, 3, and a little bit the symptom as a CKD go to the stage 4 and 5. You can see only the dialysis patients if is go to very late. I think we have to highlight again about the checkup. That's as you have a high risk patients. Patients cannot control diabetes, cannot control hypertension, still smoking. You have to advise stop smoking. In obesity, that's as we know about this obesity in CKDs, maybe aggravate the CKD progressions. We have to highlight about the control body weight. And again, I think in Thai or Asian country, you have to focus about the nephrotoxic drug. And okay, I think for the lifestyle modifications, we have to highlight about the intake, especially the salt and protein intakes. And I think the follow-up is very important because it's the most CKD patients didn't have any symptoms. And we cannot know about what is the eGFR for today's. We have to draw the blood test and recheck the creatinine frequently. And some patients might have a family history of a CKD that is a very high risk, and you have to ask to check up for the CKD management. I think the second key is a list of cardiovascular disease and cardiovascular mortality increase with the CKD progressions. And you can see in the CKDs, if people might have a CKDs, I think we have to listen to more data about the CKD increased risk of cardiovascular disease. In the advanced CKD, you can see a little bit of the cardiovascular disease, such as a sudden death from the hyperkalemia, sudden death from the volume overload and heart failures. I think we have to take care of the advanced CKDs because there are many risk factors that induce the cardiovascular disease in advanced CKD. That you would like to highlight about in eGFR less than the 45. CKD has an increased risk of non-cardiovascular mortality and cardiovascular mortality, depend on what is the KD goal risk score that we highlight, the green or yellows or the red, that you have to take care of the patients. The 3, I think the current guideline recommend is aim to early diagnosis and prompt treatment of the CKD. That's very important because early stage you can prevent the advanced CKD in the futures. I would like to highlight about the 2 guidelines from the endocrinologists and nephrologists together about the ADA and KD goal. If you see the patient as a diabetes type 2, you can see and you have to check up at the diagnosis by using the serum for eGFRs and maybe think about the UACR for screenings. Your patient is a risk management is a very low and is very high risk that you have to concern about this. As I will highlight again about the KDIGO roadmap about the KDIGO risk score. I think in this room, maybe see the early CKD such as the green, you have to 1 yearly is okay. If you see the, it's an orange and, it's a little bit the red, you have to more frequency follow up because it's maybe induce many complications if you lost follow ups and some patients cannot eat the good medications that you have. I think the fourth is that SGLT2 inhibitors can provide organ protection benefits across the cardio and renals and also metabolics in early and late stage CKD with low risk of hypoglycemia. I would like to highlight again about if you see the early CKD is, as a pink columns about in early CKD, you want to prescribe SGLT2 inhibitors might aim for glucose lowering, and use for decrease the hypoglycemic risk, a little bit the weight loss, that is the aim of early CKD. However, if you go through the late stage CKD, that we talk too much about the dangers of the late stage CKD that might induced by the sudden death from hyperkalemia. Some data show the SGLT2 inhibitor can decrease the hypokalemia. Some data show SGLT2 inhibitors can decrease the AF, atrial fibrillations. Some data show about SGLT2 inhibitors can decrease the arrhythmia. Maybe in the late stage CKD, we show data about the, established cardiovascular disease, the heart failures, and progression of CKD, and maybe additional benefits have been more publication in, I think, this decade. I would like to finally, about the message that I want to show you about. The data confirm the use SGLT2 inhibitors with the last blockade. We have to combine to optimize or decrease the CKD progressions. This slide show that is, I think, is a 20 years ago, no specific of the CKD. Some patients lost eGFR around 10 to 12. However, after that, last blockade induced, we can stop the progression of CKD only the 5. In this case, if you add SGLT2 inhibitors on top of last blockade, we can really slow eGFR progressions. Maybe we hope to 1 or 2 ml per year. That is the optimum goal that we have to achieve in this decade. Thank you very much. I think I will summarize of the key messages that I talk in these meetings. And thank you very much the audience in this room and audience at the virtuals. Okay, let me ask you a little bit the times about the evaluations by the scan QR code. You please scan QR code and send the evaluation form for improve the scientific conference in the futures. I think that is time for host this session. Thank you very much.
Khi mà mức lọc cầu tội thấp thì vẫn làm trở ngại trong việc chỉ định dùng thuốc ức chế SGLT2. Vậy với câu hỏi của một đồng nghiệp đó là khi mà dùng thuốc này thì creatinine tăng bao nhiêu so với giá trị nền thì mình có chỉ định ngừng thuốc ạ? Và xin cô cho ý kiến ạ.
Vâng, cảm ơn bạn đồng nghiệp đã hỏi và có lẽ đây cũng là một trong những câu hỏi mà rất nhiều quý đồng nghiệp đã từng hỏi chúng tôi và bản thân chúng tôi cũng đã tự hỏi cũng như là đi hỏi các chuyên gia quốc tế. Thế thì thông thường khi chúng ta sử dụng các thuốc ức chế SGLT2 như là quý đồng nghiệp biết, nó sẽ có một giai đoạn đầu tiên mức lọc cầu thận sẽ bị sụt giảm. Người ta gọi là cái nhóm mà tiếng Anh gọi là deeper. Thế thì đối với những cái người mà nghiên cứu thì họ thấy rằng ở những cái nhóm bệnh nhân mà có đáp ứng với điều trị, tức là khi mà chúng ta nhìn thấy có cái dấu hiệu giảm mức lọc cầu thận ở giai đoạn đầu thì nó lại là dấu hiệu để nói rằng đấy chính là thuốc có hiệu quả điều trị, và người ta không quá lo ngại về cái chuyện là bệnh nhân bị sụt giảm mức lọc cầu thận ban đầu, bởi vì thông thường cái tình trạng này sẽ trở về cái tình trạng ổn định hoặc là nó phục hồi lại với giá trị gần như ban đầu sau một khoảng thời gian chừng độ khoảng 12 tuần. Thế nhưng mà dĩ nhiên cũng có một số tình huống khi mà mức lọc cầu thận giảm rất là nhiều và khiến cho các bác sĩ lâm sàng rất lo lắng, và thông thường chúng tôi sẽ phải tạm dừng thuốc khi mức lọc cầu thận giảm xuống từ 30% so với giá trị nền lên. Và khi đó không phải là chúng ta nói chúng ta dừng là dừng hẳn, mà chúng ta sẽ tạm dừng thuốc để chúng ta đánh giá có những cái yếu tố nguy cơ nào làm cho mức lọc cầu thận giảm xuống một cách rõ rệt như vậy, ngoài cái yếu tố là chúng ta sử dụng thuốc. Khi chúng ta phát hiện ra những yếu tố đó, chúng ta có thể phải sửa chữa, ví dụ như tình trạng hợp các thuốc điều trị hạ huyết áp một cách, tức là chúng ta không thay đổi liều, hoặc là khi mà bệnh nhân rơi về tình trạng thiếu dịch hoặc là có một số các cái tình trạng bệnh lý khác, thì khi đó chúng ta sẽ phải điều chỉnh những cái tình trạng đó. Sau khi điều chỉnh ổn định rồi, chúng ta sẽ lại thử dùng lại thuốc SGLT2 mà chúng ta sẽ tạm dừng để rà soát các yếu tố nguy cơ. Còn nếu như trong trường hợp chúng ta đã rà soát rồi, không tìm thấy các cái dấu hiệu gì để mà chúng ta có thể sửa chữa được, mà mức lọc cầu thận vẫn tiếp tục giảm trên 30% so với giá trị nền, thì có thể chúng ta sẽ phải cân nhắc để dừng thuốc dài hạn vĩnh viễn.
Dạ vâng ạ, xin cảm ơn câu trả lời của Phó sư Hà Phan Hải An. Thưa thầy Giàng, là có một câu hỏi dành cho thầy là ở bệnh nhân đái tháo đường có bệnh thận mạn, nếu bệnh nhân đã được kiểm soát đường huyết với các thuốc hạ đường huyết khác rồi thì có cần phối hợp thêm cái thuốc ức chế SGLT2 hay không ạ? Và xin thầy cho ý kiến ạ.
Vâng, xin chào cô Hải An, xin chào tất cả các anh chị. Có một câu hỏi liên quan đến đái tháo đường, đó là nếu chúng ta muốn dựa vào cái tác dụng có lợi của ức chế SGLT2, trong lúc đó thì chúng ta biết rằng là thuốc ức chế SGLT2 ngày xưa khi tìm ra đầu tiên để điều trị đái tháo đường, nó ức chế cái sodium glucose transporter 2 ở ống lượng gần, làm cho sự tái hấp thu đường không diễn ra ở ống lượng gần. Chúng ta biết rằng 90% cái đường lọc qua cầu thận được tái hấp thu ở ống lượng gần bởi cái SGLT2. Bây giờ chúng ta ức chế nó thì làm cho sự mất đường qua nước tiểu. Sự phát hiện thuốc này đầu tiên để giúp cho khoa học đó là điều trị đái tháo đường, chứ không phải điều trị tim hay thận. Nhưng gần đây có những tác dụng khác có lợi. Hôm nay câu hỏi của bạn liên quan đến cái thận. Thế thì cái người đó có tổn thương thận, nhưng chúng ta đang dùng những thuốc đái tháo đường khác mà đường huyết kiểm soát tốt rồi, thì chúng ta có nên sử dụng ức chế SGLT2 nữa không? Có lẽ cô Hải An và chương trình hồi nãy chúng ta đã biết là ức chế SGLT2 nó có tác dụng bảo vệ thận rất rõ. Nó làm giảm albumin nhiều, nó cải thiện về mức lọc cầu thận, điều đó rất rõ rồi. Và cái vai trò đầu tiên để điều trị đái tháo đường của ức chế SGLT2 không dừng lại chỉ làm giảm glucose máu nữa, thì bây giờ nó đã vượt ra khỏi cái phạm vi của nội tiết rồi. Riêng về cái tác dụng bảo vệ thận và cả tim nữa, tôi không làm bàn tim ở đây, thì rõ ràng khi có tổn thương thận thì chúng ta nên kết hợp với ức chế SGLT2. Bởi vì những cái thuốc điều trị đái tháo đường khác, chúng ta biết rằng là thông qua cái kiểm soát glucose máu, nó cải thiện cái biến chứng mà mạch máu nhỏ, mà đó là cơ chỉnh thần kinh thứ hai, thì chúng ta để một cách gián tiếp làm chậm lại cái tổn thương mạch máu nhỏ, từ đó làm chậm lại là tổn thương cầu thận. Nhưng bây giờ SGLT2 nó có tác dụng trực tiếp luôn, một cách độc lập với đái tháo đường, độc lập với một vấn đề khác, thì nên dùng không? Tôi nghĩ là nên dùng, nhưng lưu ý thế này, chúng ta đang dùng những thuốc khác mà kiểm soát đường huyết tốt rồi, bây giờ thêm một loại điều trị làm hạ đường huyết nữa. Cái điều đáng sợ nhất là hạ đường huyết. Tuy nhiên chúng ta chú ý điểm này, đó là ức chế SGLT2 tai biến hạ đường huyết là ít, nhưng khi phối hợp lại là vấn đề. Do đó cái câu hỏi của bạn rất là hay. Theo tôi là nên dùng, nhưng khi nên dùng ức chế SGLT2 để lợi dụng cái tác dụng trên thận, có lợi trên thận, nhưng hãy lưu ý chúng ta đang dùng những thuốc khác, ví dụ như metformin hoặc thậm chí cả insulin rồi, đường là tốt, bây giờ kết hợp thêm một loại nữa thì coi chừng hạ đường huyết. Do đó thì các bạn phải theo dõi glucose máu tốt hơn, và thậm chí một cách rất tương đối xem xét có thể giảm những cái thuốc điều trị đái tháo đường đang dùng kia đi. Tất nhiên chúng ta phải trở lại một cái lộ trình kết hợp với cái ức chế SGLT2 hôm nay nữa, thì bên kia chúng ta giảm bao nhiêu? để chúng ta có được một cái glucose máu đói đạt theo yêu cầu mà không bị hạ đường huyết. Tóm lại, nếu tổn thương thận, đái đường, đã dùng thuốc đái đường mà tốt rồi thì theo tôi nên dùng ức chế NT2. Nhưng khi dùng thì coi chừng có thể bị hạ glucose máu. Do đó chúng ta phải kiểm soát đường huyết, theo dõi đường huyết kỳ hơn và xem xét giảm đi các cái loại thuốc điều trị đái đường khác đang điều trị, giảm đi liều lượng, thậm chí có thể giảm loại thuốc nếu như chúng ta dùng nhiều loại thuốc. Tôi chỉ có ý kiến sơ bộ ban đầu như vậy. Xin cảm ơn câu hỏi.
Dạ vâng ạ, em cảm ơn thầy. Như vậy chắc là quý đồng nghiệp cũng có cái câu trả lời rất là rõ ràng của thầy Giàng rồi ạ. Sau đây có một bạn hỏi là vừa giờ là đội ngũ kỹ thuật cho hiện lên câu hỏi đúng không ạ? Là có bạn đây tôi thấy hỏi là thầy cô cho em hỏi bệnh nhân bị suy tim EF 35%, nếu áp là 120/70 thì nên dùng ức chế SGLT2 hay là ức chế tự thể? Vâng, câu này thì thuộc lĩnh vực tim mạch thì tôi nghĩ tôi có thể trả lời cho bạn như sau. Thứ nhất là trong bản cập nhật mới nhất năm 2021 về điều trị suy tim của Hiệp hội Tim mạch châu Âu thì cả hai cái nhóm thuốc đó là ức chế hệ RAS và ức chế SGLT2 đều là 2 trong số 4 cột trụ, và quan điểm bây giờ là dùng đồng thời ngay lập tức 4 cột trụ, chứ chúng ta không có cho từng thuốc một rồi thấy không đạt yêu cầu chúng ta mới cho. Đặc biệt là cách đây 3 tháng vào đầu năm 2023 này, trên tờ Lancet có một nghiên cứu là nếu chúng ta tối ưu cái số lượng thuốc ngay từ đầu cho tất cả 4 thuốc, và nếu bệnh nhân dung nạp được thì hiệu quả giảm tỷ lệ tái nhập viện vì suy tim nó tốt hơn là chúng ta cứ cho lần lượt từng thuốc một. Trước kia cái cách tiếp cận chúng ta là chúng ta cho ức chế men truyền, sau đó thấy mà tình trạng vẫn suy tim cho thêm chạy beta, cho lợi tiểu kháng testosterone, sau đó chúng ta cho ức chế SGLT2. Điều quan điểm là thay đổi rồi. Vậy quay lại với câu hỏi của bạn thì tôi nghĩ là chúng ta EF dưới 35% từ suy tim EF giảm. Như vậy cả hai nhóm thuốc này được chứng minh là cải thiện tiên lượng và cải thiện triệu chứng, giảm tỷ lệ nhập viện ở bệnh nhân suy tim EF giảm. Vậy các bạn có thể cho đồng thời. Tất nhiên bạn phải lưu ý những cái chống chỉ định của nó. Và tiếp theo có một câu hỏi có lẽ là dành cho Phó Giáo sư Hà Phan Hải An. Xin thầy cô chia sẻ việc quản lý bệnh thận mạng ở các bệnh nhân có bệnh lý tim mạch hoặc bệnh lý đồng mắc khác. Mời cô An.
Vâng ạ. Cảm ơn quý đồng nghiệp đã có một cái câu hỏi thực sự là khó đấy ạ. Đây là một cái câu hỏi mà đòi hỏi nó phải tổng hợp rất là nhiều thứ, bởi vì chúng ta cũng biết là đối với các bệnh nhân mà bị bệnh thận mạng thì thường là bao giờ cũng có những cái biến cố về tim mạch, cái đấy là rất là thường gặp. Và hơn nữa là bản thân những cái bệnh nhân bị bệnh thận mạng đôi khi họ sẽ tử vong vì biến cố tim mạch trước khi họ đi đến bệnh thận giai đoạn cuối. Vì vậy cho nên là chúng ta thấy rằng để mà quản lý được tim mạch ở bệnh thận mạng thì đây là một nhiệm vụ khá là khó khăn và cũng là một trong những cái mục tiêu để điều trị. Cái thứ hai nữa là những cái bệnh đồng mắc khác thì cái này chúng ta cũng thấy là nó vô cùng nhiều, bởi vì bản thân bệnh thận mạng cũng là một cái hội chứng bao gồm rất nhiều các cái loại bệnh lý nguyên nhân khác nhau. Vì vậy cho nên chúng ta cũng thấy rằng là để mà có được một câu trả lời là quản lý một cách tổng thể tất cả các bệnh nhân bị bệnh thận mạng thì nó rất là khó. Thế tuy nhiên chúng tôi xin có một vài cái ý kiến nhỏ như thế này. Việc thứ nhất đó là chúng ta sẽ phải làm thế nào để tìm hiểu xem là yếu tố nguy cơ của bệnh nhân đối với những cái người mà bị bệnh thận mạng ở cụ thể nào đó là những yếu tố nguy cơ gì. Chúng ta sẽ cần phải nhắm vào những cái mục tiêu nào để chúng ta giải quyết vấn đề và cái nào là cái đặt theo thứ tự ưu tiên. Nếu trong trường hợp chúng ta đặt ra được những cái yếu tố nguy cơ theo thứ tự ưu tiên từ cao xuống thấp thì chúng ta sẽ biết được rằng chúng ta nên giải quyết bằng cách nào. Và cái cách tốt nhất trong cái vấn đề lựa chọn điều trị đó là chúng ta chọn một cái loại thuốc có thể tác động được lên nhiều yếu tố nguy cơ khác nhau. Ví dụ nếu chúng ta nói về một bệnh nhân bị đái tháo đường, có tổn thương thận, có suy tim, có tăng huyết áp, có rối loạn lipid máu, có tăng axit uric máu, ví dụ thế, chúng ta sẽ phải đặt mục tiêu là chúng ta cần làm cái gì. Chúng ta quản lý đái tháo đường, chúng ta quản lý tim mạch, chúng ta quản lý tình trạng tổn thương thận và đồng thời chúng ta cũng phải giải quyết tốt những cái trạng thái như là rối loạn lipid máu hay là tăng axit uric. Vậy thì cái gì là cái mà có thể giúp cho chúng ta có thể quản lý được những tình trạng đó, nhưng với một điều kiện đó là làm thế nào để đơn giản hóa phác đồ điều trị, làm thế nào để giảm thiểu các yếu tố nguy cơ liên quan đến tai biến hoặc là các biến cố bất lợi của thuốc hoặc là các biện pháp điều trị. Thì đấy là những cái để chúng ta cân nhắc, chúng ta lựa chọn. Bởi vì trong những cái tình huống như vậy, có thể chúng ta sẽ có những cái lựa chọn tối ưu cho cái loại biến cố nguy cơ này hay là cho loại biến cố nguy cơ khác. Thế và chính vì vậy cho nên là chúng ta không thể đưa ra được một cái công thức rất là cứng nhắc cho tất cả các tình trạng, mà chúng ta sẽ phải đặt những cái yếu tố nguy cơ lên và sắp xếp nó theo mức độ ưu tiên, và sau đó chúng ta sẽ rà soát lại trong cái kho vũ khí của chúng ta có những cái vũ khí nào, cái nào là cái mà một mũi tên có thể bắn được vào nhiều mục đích, thì khi đó chúng ta sẽ có được cái chiến lược kiểm soát tổng thể. Và bên cạnh cái việc sử dụng thuốc, chúng ta cũng không nên quên những biện pháp không thuốc, chẳng hạn kiểm soát về cân nặng, kiểm soát về chế độ ăn, rồi luyện tập, rồi hút thuốc, uống rượu, những cái thói quen không tốt trong cuộc sống. Thì đấy là những cái mà chúng ta cũng cần phải lưu ý để chúng ta có được cái chiến lược kiểm soát bệnh nhân toàn diện. Bác sĩ Linh.
Dạ vâng, em xin lỗi. Xin cảm ơn cái câu trả lời rất là chi tiết và khoa học của phó sư Hà Văn Hải An. Thì sau đây có một câu hỏi nữa là về tầm soát phát hiện bệnh thận mạng ở những cơ sở y tế không có điều kiện làm xét nghiệm mà microalbumin niệu, phải không? Chắc là thế ạ. Làm nào để phát hiện ra bệnh thận mạng sớm, và nhờ cô An cũng chia sẻ.
Dạ vâng ạ. Vâng, đúng là một câu hỏi rất thực tế, và tôi nghĩ là đây là những người mà nói là làm việc trong những điều kiện mà rất là đúng là của Việt Nam đấy, thì đưa ra những cái câu hỏi như thế này. Tôi nghĩ là cái gọi là lý tưởng đó là chúng ta có thể phát hiện bằng cách là tầm soát microalbumin ở trong nước tiểu. Đấy là phương pháp giúp cho chúng ta có thể xác định được cái tổn thương thận ở cái thời gian là sớm nhất. Tuy nhiên nếu chúng ta không có microalbumin hoặc chúng ta không có xét nghiệm albumin thì chúng ta cũng chấp nhận là có thể làm cái xét nghiệm protein trong nước tiểu. Tuy nhiên chúng ta cũng biết rằng là protein trong nước tiểu thì không phải lúc nào cũng là cái dấu hiệu của tổn thương cầu thận, mà nó có thể là dấu hiệu của tổn thương cả ống kẽ thận nữa. Và vì vậy cho nên là khi chúng ta làm cái chỉ số protein trong nước tiểu thì chúng ta cũng hết sức lưu ý là để chúng ta phân biệt ra nó là protein của cầu thận hay nó là protein của ống thận. Thông thường chúng ta sẽ có cái test thử bằng que nhúng để mà chúng ta phát hiện ra protein, và khi cái test này dương tính thì thường nó là protein của cầu thận. Bên cạnh cái việc đánh giá để phát hiện ra cái protein hay là albumin ở trong nước tiểu thì các quý đồng nghiệp cũng không nên quên cái chỉ dấu gọi là mức lọc cầu thận. Và chúng ta phải ước tính mức lọc cầu thận, bởi vì có rất nhiều trường hợp nếu chúng ta muốn phát hiện sớm bệnh thận mạng, không phải chúng ta chỉ dựa vào duy nhất một cái dấu hiệu đấy là phát hiện microalbumin hay là albumin hay là protein trong nước tiểu, mà chúng ta còn có một tiêu chuẩn nữa, đó là mức lọc cầu thận giảm xuống dưới 60 ml/phút. Vì vậy cho nên trong cái khuyến cáo của KDIGO thì người ta khuyến cáo rằng chúng ta không nên chỉ dùng một biện pháp để tầm soát, mà chúng ta nên dùng cả hai biện pháp phối hợp với nhau thì chúng ta không bỏ sót các bệnh nhân.
Rất cảm ơn câu trả lời của phó giáo sư Hà Phan Hải An. Và một câu nữa thì không biết là thầy Giàng cũng là một chuyên gia về nội tiết chuyển hóa, cũng rất nhiều kinh nghiệm. Thầy cho ý kiến là mức lọc cầu thận từ bao nhiêu có thể bắt đầu dùng cái thuốc ức chế SGLT2 ạ? Và làm người có rất nhiều năm kinh nghiệm trong ngành lâm sàng thì thầy có chia sẻ gì về kinh nghiệm dùng thuốc này ở những bệnh nhân cao tuổi không ạ? Mời thầy ạ.
Trước hết bạn đưa một câu hỏi dễ ngộ nhận, mức lọc cầu thận từ bao nhiêu thì có thể bắt đầu dùng. Tôi thì hiểu ngược lại, mức lọc cầu thận bao nhiêu thì không dùng. Cầu thận không phải từ bao nhiêu, tức là những cái người đái tháo đường chẳng hạn và mức lọc cầu thận bình thường thì chúng ta dùng cách thoải mái. Và bây giờ tôi xin nói cụ thể, có lẽ tôi hiểu cái ý bạn là như vậy. Thế thì ức chế SGLT2 là một cái thuốc mà không những làm hạ glucose cho máu là yêu cầu chính của điều trị đái tháo đường, mà thuốc đã chứng minh là bảo vệ tim rất là tốt. Như chuyên gia về tim mạch vừa nói đấy, những cái người suy tim, phân xúc tổng máu là bảo tồn hay là giảm đều dùng ức chế SGLT2 đều tốt cả. Và bây giờ Bộ Y tế đã duyệt rồi, cho phép chúng ta dùng ức chế SGLT2 để điều trị suy tim độc lập với đái tháo đường. rõ rồi. Và hôm nay chúng ta thảo luận là thậm chí ngày mai nữa thưa cô Hải An, có khi Bộ Y tế chúng ta sẽ bắt chước theo là ăn bây giờ người ta đã hướng dẫn ở đấy, có thể dùng ức chế thứ hai cho những người tổn thương thận độc lập với những bệnh lý khác, kể cả đái tháo đường hay không. Thế thì đái tháo đường thì hiện tại chúng tôi rất là trân trọng cái tác dụng ức chế thứ hai. Cái ý khi này cô Hải An nêu chúng tôi rất là đồng tình, một mũi tên mà có thể có được nhiều đích. Như vậy dùng ức chế thứ hai, chúng ta biết rằng là tổn thương thận trong đái tháo đường là chiếm cái nguyên nhân tử vong đến khoảng xung quanh 10% sau tim mạch thôi. Thế thì nếu chúng ta dùng điều trị đái tháo đường mà không những làm kiểm soát đường tốt mà còn có tác dụng trực tiếp trên bảo vệ thận nữa thì chúng ta dùng ngay ở mọi mức lọc cầu thận. Tuy nhiên hiện tại thì tôi xin nói những con số này, bởi vì trong chuyên ngành đái tháo đường chúng tôi rất là quan tâm. Hiện tại Bộ Y tế chỉ cho phép chúng ta dùng dapagliflozin với mức lọc cầu thận là khoảng xung quanh 30 gì đấy. Gliflozin thì cho dùng là ở mức độ là ở đái tháo đường, mà dùng EMPA thì mức lọc cầu thận 45 là người ta không cho dùng rồi. Điều đó là chúng ta phải cập nhật thôi. Về hiện tại Hội Nội tiết chúng tôi đang là cập nhật này đây. Thì theo FDA á, với cái EMPA gliflozin người ta có thể dùng cho những người đái tháo đường có mức lọc cầu thận là 30 đến 30 thì chúng ta dùng. Còn tác dụng có lời thì cô Hải An nói rồi, tôi không nhắc lại nữa. Dùng nó để bảo vệ thận rất là tốt, ngoài cái chuyện bảo vệ làm giảm glucose máu ra. Còn những người suy tim thì FDA người ta là approve về đến cái mức là mức lọc cầu thận đến 20. Và đối với những người tổn thương thận ở trong đái tháo đường ở Mỹ, ở FDA người ta là cho dùng để những mức lọc cầu thận đến 20 ml phút trên 1,7 bàn vuông da. Có thể nói rằng là tóm lại thế này, nếu điều trị đái tháo đường chúng ta có nhiều lựa chọn. Thuốc đầu tiên luôn luôn là metformin, nhưng nếu như bệnh nhân có vấn đề về thận, vấn đề về tim, không những để điều trị mà bảo tồn thì chúng ta nên dùng cái thuốc này sớm. Nhưng lưu ý là chống chỉ định của chúng ta đó là mức lọc cầu thận trong hiện tại là 45, đối với đái tháo đường thì không dùng nữa. Nhưng chúng tôi đang cập nhật cái này đây, và hy vọng là Cục Quản lý Khám chữa bệnh sẽ đồng thuận với chúng ta, bởi vì người ta dùng đến vị trí thấp hơn rất là nhiều. Còn tôi nói con số vừa rồi để tham khảo, tức là do những tác dụng gọi lời của nó, các bạn hãy dùng ngay empagliflozin ở bệnh nhân đái tháo đường. Chỉ không dùng khi nào mức lọc cầu thận dưới 45 trong hoàn cảnh Việt Nam mình. Nhưng mà ở Mỹ thì người ta cho dùng đến mức lọc cầu thận 30 đối với những người bệnh thận đái tháo đường, ở những người đái tháo đường. Và những cái người suy tím thì có thể dùng đến mức lọc cầu thận ở Mỹ người ta dùng đến 20. Và chi tiết này tôi xin nêu này, ở Việt Nam mình cũng là có một cái chuyện hơi là không công bằng lắm. Tức là với bệnh nhân đái tháo đường dùng empagliflozin thì chúng tôi chỉ được chỉ định ở mức lọc cầu thận 45 mà thôi. Nhưng ở bên tim người ta cho dùng đến mức 30 đấy. Rất là bên tim nghĩa là dùng empagliflozin để điều trị suy tim thì có thể dùng đến mức lọc cầu thận là 30 ml phút trên 1,7 ml da. Tôi xin được cung cấp thông tin như vậy để các bạn tham khảo. Nhưng mà tôi nghĩ rằng với thế giới bây giờ, thế giới phẳng, chúng ta không thể chậm lại được nữa, và chúng ta sẽ chuyên môn chúng ta sẽ tham mưu với Bộ Y tế. Khi mà thế giới người ta đã công nhận mức lọc cầu thận thấp hơn thì chúng ta nay mai tôi nghĩ rằng, tôi hy vọng không lâu nữa chúng ta sẽ có những cái hướng dẫn đầy đủ hơn với cái chỉ định là ức chế thứ hai với mức lọc cầu thận thấp hơn là hiện tại mà Bộ Y tế đang cho phép. Xin cảm ơn câu hỏi.
Ơn câu trả lời của thầy Giang. Như vậy hy vọng là bạn đồng nghiệp đã có câu trả lời rồi. Còn ở đây tiện đây cũng nhờ thầy Giang chia sẻ thêm về việc sử dụng sớm cái thuốc ức chế SGLT2 để bảo vệ thận cho bệnh nhân đái tháo đường. Khi nào nên, tức là dùng sớm đến chừng nào? Ngay lập tức, ngay khi chẩn đoán, hay là sau một thời gian đã có protein niệu rồi? Và khi nào nên dùng và khi nào không nên bắt đầu sử dụng? Mời thầy ạ.
Tôi xin thưa thế này, tất nhiên cái guideline của chúng ta ở Bộ Y tế, thuốc đầu tiên đái đường type 2 vẫn là metformin. Điều đó không sai, đây là thuốc thiết yếu mà Tổ chức Y tế Thế giới và Bộ Y tế chúng ta cũng vậy. Thuốc nó rẻ để tai biến hạ đường huyết, đồng ý. Tuy nhiên gần đây với cái tác dụng rất là tốt, tác dụng có nhiều cái gì làm giảm glucose máu, đó là bảo vệ tim và bảo vệ thận. Không những làm lùi diễn tiến mà bảo vệ và phòng ngừa đã chứng minh bằng những nghiên cứu khác nhau rồi. Thành thử là quan điểm cá nhân tôi là nếu như có tổn thương thận mà trong chỉ định nên còn được thì dùng ngay, không có bàn cãi. Có tổn thương tim mà trong bối cảnh đang chỉ định là dùng ngay. nếu có kèm đái tháo đường. Nhưng câu hỏi đặt ra, tôi chỉ nói ý kiến cá nhân thôi. Thế thì một bệnh nhân đái tháo đường chưa có tổn thương thận, tổn thương tim thì chúng ta dùng cái gì ạ? Tất nhiên theo guideline hiện nay vẫn là metformin, nhưng ai cấm chúng ta có thể dùng âm bạc lysergin ngay, bởi vì cái tác dụng bảo vệ không những là làm lui mà là bảo vệ là có. Thì cả đó tôi nghĩ là mỗi người có quyền lựa chọn của mình. Tuy nhiên thì dù sao là chúng ta đang sống ở Việt Nam, chúng ta phải chấp hành theo cái hướng dẫn của Bộ Y tế. Nhưng theo tôi là nên chỉ định sớm. Tất nhiên vấn đề cái giá thành là cần phải quan tâm một chút, bởi vì metformin thuốc thiết yếu không phải ngầu, nhưng bởi vì nó rẻ, rất rẻ, mà nó làm giảm HbA1c cũng rất là cao. Ampagliflozin nó giảm HbA1c xung quanh 1% mà thôi, trong lúc đó là metformin nó giảm đến gần 2%. Quyền các bạn thôi, nhưng theo tôi nghĩ rằng nếu như mà chúng ta quan tâm đến những cái biến chứng mà gây tử vong này, đó là tim, là thận ở bệnh nhân đái tháo đường, nên dùng sớm. Quan điểm cá nhân tôi là như thế, và tôi nghĩ rằng nhiều nơi người ta đã áp dụng như vậy rồi, trong riêng cá nhân tôi. Xin cảm ơn câu hỏi của bạn.
Dạ vâng ạ, em cảm ơn thầy giảng ạ. Câu này chắc là dành cho phó sư Hà Phan Hải An. So với các nghiên cứu trước đây ở bệnh nhân bệnh tật mạng thì nghiên cứu EMPA KIDNEY giúp bổ sung chứng cứ về hiệu quả của empagliflozin của bệnh nhân bệnh tật mạng như thế nào ạ? Nhờ cô chia sẻ kỹ hơn cho những các bạn này. Về cái nghiên cứu này em rất là thú vị đấy ạ.
Xin cảm ơn quý đồng nghiệp đã hỏi. Thực ra đây là một câu hỏi cũng rất là thực tiễn, và chúng tôi nghĩ rằng là nó sẽ giúp cho chúng ta làm rõ thêm một số những cái vấn đề. Bởi vì trước đây chúng ta biết là các thuốc ức chế OCT2 như là empagliflozin, dapagliflozin, vân vân, canagliflozin chúng ta mới chỉ đầu tiên là nghiên cứu ở những bệnh nhân bị bệnh tiểu đường. Sau đó thì người ta thấy rằng cái tác dụng có lợi trên các nhóm bệnh nhân bị bệnh thật thì người ta mở rộng ra cả những bệnh nhân không bị tiểu đường. Và cái nghiên cứu EMPA KIDNEY là một cái nghiên cứu mà cái đối tượng quần thể nghiên cứu được mở rộng ra hơn nữa, mở rộng ở hai khía cạnh. Khía cạnh thứ nhất đó là về mức lọc cầu thận, tức là chúng ta thấy rằng nghiên cứu EMPA KIDNEY đã cho chúng ta cái giới